More recently, it's been exciting because many surgical centers are referring patients to me who've had failed spine surgery. The patients are either being referred from their surgeons or the patients come on their own because they've had friends or others, relatives who've had success after failing fusions or failing discectomies. And so these surgeons call me back after I help their patients get better, after multiple failed spine surgeries, asking me why. And so I thought about it, and I tried to determine, and I think I brought it in to three primary reasons why the Discseel procedure helps patients who've previously underwent spine surgery and failed. Well, the one reason is that very often after a fusion or even the discectomy, it's going to change the mechanics of the spine. I say often, but actually, the fusion or an artificial disc does change the adjacent disc and it causes problems there. We thought the artificial disc would be the answer, the panacea, but the research has shown no, we can't mimic nature. So anyway, when these patients come to me after failed surgeries, I think one of the reasons that I help them is because I'm able to address the domino effect. So instead of worsening that domino effect by fusing the next segment adjacent, we're treating that next segment. We're actually causing that next segment to heal and to regrow. And another reason that patients get relief who've had prior surgery is because when they have their fusions, the surgeons tend to leave most of the disc there. And it doesn't make sense. And if you think about it, the fusion was developed in 1911. It was never even meant to treat disc pain. It was meant to treat instability caused by cancer or trauma. It was back in the years of the Model T Ford, yet they still do it today. Never been meant to do that. But anyway, they're fusing discs that are leaking. They can't correct the leaks. The discs keep leaking. And so with every patient that comes to me every week, when it's a patient with a fusion, I still test that level that's fused. It's easy to do. I direct the annular needle down to that level that's fused, and if I see that it's leaking, I treat that leaking disc that's already fused. Historically, the surgeon said to me, "No, Dr. Pauza, that disc's out of play. We took care of it. We fused it." Well, no. They left that leaky disc there. A surgeon can't sew a disc that's leaking. It's like sewing crab meat. So the Discseel addresses that. It also addresses the adjacent discs that are now breaking down more than they were before because of the fusion. And the MRI doesn't pick that up. The MRI might not show those problems. Very often it doesn't show those problems, and it requires the annulogram that I do during the Discseel to identify those tears. And another issue to think about is that it tends not to be the hardware that causes pain. And I know so many patients have hardware implanted and then have it removed. I just saw a patient who is from one of the top spine surgeries in the country, so they claim in their marketing ads. He underwent his 11th spine surgery. They were putting in rods, taking them out, doing different levels. So I treated him. I did the annulogram, identified his symptoms and treated him, and he's doing well. He's back to playing golf. He hadn't done that in over a decade. And so the fusion is being done at the wrong levels, number one. Number two, they don't have the ability to address the tears. Number three, it's causing adjacent discs to break down. The fusion, the discectomy, the laminectomy, none of them can address the true problem. The true problem is the leaky disc. So they can operate as much as they want on a spine. Those patients will ultimately come to me after their first surgery or their 10th surgery, and we'll identify their problem with the annulogram and treat them with the Discseel procedure, and they'll be happy people, active into the future.